Thanks, Isaac, and it's a great joy to welcome you all to this final TMC seminar of the spring semester. I'm especially delighted to welcome my friend Karl Johnson, who, despite the lighter and lesser shade of blue that he's affiliated with, is doing remarkable work in the field of public health. He's an assistant professor of public health leadership and practice at UNC Gilling School of Global Public Health. He thinks wisely and deeply about the current landscape of public health and how to act faithfully within it. And he spends a good bit of time with friends and partners in Granville and Vance County here in North Carolina, which is a great testament to the way that he's learning from the ground up what it means for faith communities and public health departments and universities and other folks on the ground to do really innovative and faithful work together. So I'm delighted that we get to learn from my friend Karl today. And without further ado, Karl, the floor is yours.
Thank you, Brett. I feel like I have to give the traditional UNC Duke joke, but I'm kind of embarrassed by our recent loss, getting kicked out of the tournament. So I just hope I can represent my alma mater a bit better, but we'll see. Let me share my screens. All right. Can y'all see the screen well? Yep. Okay. So today I'd like to talk about health and friendship and how I think uh, something like friendship should be more intentionally pursued within public health. So there are kind of two or three broad talk parts of my talk. First, I want to be descriptive, tell some stories about two different models I see in public health. One I'll call population health management. The other I'll call health through friendship. And I have some images or stories that I think are reflective of either model. Two, I want to be explanative. I want to think through what are some assumptions or ideas that I think drive public health towards the population health management model in general, and therefore how we can shift things a little bit back towards what I call health through friendship. And then hopefully, if time permits, I'll do a little bit of normative work in terms of why we should pursue health through friendship as opposed to what I call population health management. So, I want to begin by telling just a few stories or offering a couple different images for reflection. So, I'll start off with what I call five images of this model of doing public health that I call population health management. Um, the first one begins as my first exposure to public health when I was a undergraduate at Johns Hopkins. I had joined a research group at the Bloomberg School of Public Health that was studying the cost effectiveness of active case finding for folks with latent tuberculosis in Cambodia. I remember joining this group when they received a contract from the WHO to develop a decision-making model to assess the cost effectiveness of different interventions. So I looked up different statistics, from different academic literature on the prevalence of TB in different areas and the effectiveness of the intervention, the cost, as well as what they call the utility of having tuberculosis, a measure of 0 to 1 of basically how bad it is, to have TB. There's multiple estimates for that, 0.45, zero point 0.5, 0.56. But those were used to inform the development of this model to test the overall cost effectiveness. Um, and I've always been intrigued by kind of this initial exposure I had to public health. I remember thinking, how is I, a 20-year-old student in Baltimore, somehow involved in this kind of decision? How could so much of it have been done on my computer through a spreadsheet? I remember calibrating all the models to spit out different graphs like you see there. We actually used this model for multiple different countries. We just kind of had to update the parameters a bit for different disease prevalences. And I remember thinking, is this what public health research and is this what public health practice looks like? As Brett mentioned, I work in Granville and Vance County at the health department. in which very early on in that position, I was asked to give a talk on trauma-informed care to social workers and nurses at the clinic. For those who are familiar, trauma is perhaps one of the most personally sensitive or emotionally complex topic. It pertains to so many difficult circumstances of life, from chronic unemployment to substance use and addiction, to financial instability, domestic violence, and how all these things, especially one's youth, may impact health later on. So there I was at the front of this classroom, having read all the kind of social science literature on the likelihood of having chronic diabetes or COPD or depression, based on the number of adverse childhood events one experienced. I went through all of that literature. I discussed the various kind of evidence-based practices to make the clinical environment more trauma informed. Painting the wallpaper a different color, adding background music, etc. And I remember I gave this whole presentation, myself not having had direct experience with adverse childhood events, nearly to the extent that we were kind of addressing and not being a part of that community as well. I remember there not being a lot of discussions or questions at the very end. The presentation was given, and that was basically it. And I'm not really sure the outcome of that in any of the individual lives of the folks that I was with. Additionally, the health department I've worked with has worked with a school district to address youth mental health, especially anxiety and depression in the classroom or in school-based settings. And so one of the so-called evidence-based practices to do so is to implement these things called calming rooms, which are basically what you see on the graphic there, a place in the room or even a separate room that has various toys, games, activities to help students calm down, especially if they're experiencing some kind of anxiety. And yeah, I remember when we implemented this, immediately the school leadership told us that it wasn't working. Students were using these things for the wrong purposes. They were going to the calming rooms to vape or otherwise, do stuff that they couldn't do in the classroom. It was causing a disruption ultimately. And yeah, I remember when we received that feedback, there was a different staff member at the health department who insisted that, because this was an evidence-based practice, it had to work somehow. The issue was likely in how it was being implemented or some detail that we could work around, and when it, when it says evidence-based, it really means, this has been implemented somewhere else, and likely they had some kind of surveys of students, that likely reported, some kind of effectiveness of this kind of space. And so it seemed as though that, the evidence, so to speak, of this intervention elsewhere was being more demonstrative than the feedback that we were receiving directly from school leadership, who are seeing the effect of this thing on the ground. I remember there being a kind of disparity there, and especially in that pushback. Another example, so in her work, Life Besides Itself, Lisa Stevenson, who's an anthropologist or ethnographer, tells the story of the Canadian state's response to two different epidemics, one TB, the other of youth suicide among the Inuit people throughout the 20th century. To mitigate the spread of TB among the Inuit people, the Canadian state ended up forcibly removing thousands of Inuit members to sanatoriums, further south in the country, as well as introducing a number of statistical techniques to measure and evaluate the success of the program, including, as you see there, basically transforming all the names of the Inuit people into statistics, this diskless number that could be more easily used to track them. In many instances, family members who were taken down south, so to speak, never saw their loved ones again. And they received only a very limited information about how they're being cared for in the sanatoriums. Efforts to mitigate the spread of disease also led to the destruction of several Inuit hunting villages because it was presumed that that was where disease spread more rapidly. And lastly, in 2024, the World Health Organization released their SARA chatbot, which just means, or is an acronym for Smart AI Resource for Health. And it was promised to democratize access to health information. Like any AI chatbot you see online, you can access it at all times from wherever in the world. And on their website, the WHO insisted that, quote, the expertise that Sarah had was able to prevent some of the biggest causes of death in the world, including cancer, heart disease, lung disease, and diabetes. So those are five images or aspects of what I call population health management. I want to shift to provide five examples of, I think, aspects of health through friendship. And these are all individuals I've had the joy of meeting and working alongside over the last, several years within my own career. Um, the first is Alex Fajardo. So during the pandemic, I was involved in the development of the Community-Based Workforce Alliance. It was a national entity composed of a lot of CHW-led, community health worker-led agencies, including El Sol, which is where Alex is the director. Um, Community health workers, for those who aren't familiar, are defined by a few interrelated characteristics. Their local knowledge of a particular community, in this case, San Bernardino, California, in a particular neighborhood, even within there. Their belonging to that community, therefore the trust they have with that community, and then the wide range of activities they're often equipped to pursue, certainly including health education, but often expanding into things like community organizing around health. Many of them, though not all, will have some kind of lived experience with the health-related topic in question. I think it's remarkable that CHWs, in contrast to most other members of the public health workforce, are primarily defined by who they are and where they come from, and not necessarily just what they know. So I had a chance to work a lot with Alex and some of the CHWs from El Sol throughout the pandemic. I did a number of interviews with them. We listened to some of the stories they had from the front line. And as I learned, the folks working at El Sol, again, they do health education and they do so in the context of their Latino heritage. But they've also been involved in a lot of other initiatives in the community. They've worked to address school absenteeism, in the school district. They develop mentoring opportunities for low-income youth. They've worked to advocate for safer places to exercise and recreate in the community. It's really a remarkable workforce, and I had the pleasure of getting to know some of them during the pandemic. Um, Likewise, I've had the joy of getting to know Kim McCann. Kim is a peer support specialist with the North Carolina Harm Reduction Coalition here in North Carolina. She's a native of Granville County. Um, Kim, as the title peer support specialist suggests, has herself lived experience with opioid dependency, though she is now in long-term recovery. She's hired by the North Carolina Harm Reduction Coalition, often subcontracted with our health department to operate a syringe services program, a mobile clinic really, throughout the two-county district. I remember one time I got to observe Kim at work. She invited me to join her Advanced Recovery, which is a methadone clinic in Henderson, where she had her booth of harm reduction supplies starting at 6 in the morning, as that's when these lines form. It was her who was able to have, these delicate conversations about substance misuse, about the role of harm reduction in mitigating that. She knew many of the people we met by name. They knew her by name. It was clear that she had the right tact to have these conversations, to know when to offer these supplies and to know when not to. I remember in many cases she would talk with people who are, going through this clinic for, an extended period to really get to know who they were and what their concerns were. She's a really amazing individual. I've also been inspired by the work of Dr. Stan Winborn, who's the superintendent in Granville County Public Schools. Stan, like myself, often think that at least one core environmental driver of youth mental health or youth mental illness is a kind of an excessive dependency on digital technologies, on screen dependency, access to social media, etc. Certainly not the only thing going on, but a huge factor in it, as well as the way in which a kind of excess of education technology can get in the way of learning and developing, pro-social, in-person relationships. Stan is one of the few districts across the state that has implemented entire restriction on access to cell phones and other wireless technologies, as you see in the off and away sign. He's also implemented, I think, the first in the country, to my knowledge, a total restriction on technology in the classroom on Tuesdays and Thursdays throughout the semester. Um, we've had a great partnership ever since I've met him. We've written blog posts together. We presented at various conferences together. We do workshops with other superintendents, with other school leadership. Again, trying to think about how the school system itself can be a kind of sanctuary for students, in the context of learning. Likewise, I've had the joy of getting to know Mary Beth Roche. Mary Beth is a parent of children, obviously, in the Chapel Hill Carborough City Schools. She has developed this coalition that's called CHCCS, Parents for Intentional Tech, which is likewise advocating for a more intentional approach to technology in the classroom, in particular, the district that we both belong to. Mary Brath is an amazing individual. This coalition started as, maybe a dozen parents a couple years ago and is now, 300 or more strong. She facilitates workshops on these topics. She's had a position at a coalition, or rather a committee that the school district has put together on thinking about the role of technology in the classroom. Ever since we've met, we've had a joy of strategizing about these topics, of learning from one another. We've written various op-eds together, as you see one of them there. We've met members of the General Assembly together to talk about these topics. Mary Beth comes to this work as a parent. She sees the effect of this, both on the mental health, but also on the learning of her children, but then, cares to address it, for other members in the community as well. And then lastly, I'll mention Reverend Frank Sossaman. So Frank is a pastor I met several years ago in the district. He's a former representative of the district as well. Um, Pastor Frank has a huge heart for the topic of mental illness and substance misuse. And we had a conversation, this is probably 2 or 3 years ago now, in which he was just trying to suggest, how he would love for more churches in the district to be more aware of this topic, to be more engaged in addressing this topic, both within their congregation and in the broader community. And so really with his leadership and some of my support and others from the health department, as well as the state health department, we put together this program we call Faith and Mental Health, which is basically a way to equip, encourage, empower individual churches throughout the district to learn about this topic, to develop ministries to address this topic, sermon series, Bible studies. It's really been a remarkable experience, and I really have looked to Frank in many instances, as the leader of this kind of initiative. It's clear whenever I grab coffee with him or grab lunch with him, anywhere we go, he knows basically everyone that ever walks into the door, and our conversations are always being interrupted, by him catching up with someone and saying hello to someone. He's an amazing community organizer, and I've learned a lot from him, specifically around this work. So those are 5 stories, or 10 rather, 5, that I can generally represent this kind of population health management approach, and 10 that represent health through friendship. So I want to at least make an attempt at explaining, what I think are the differences here, and why do I think public health tends towards, the first set of stories than the latter. These are just a couple of ideas I have, and I'm sure there are more that could be thought about or offered. But just as initial kind of point of departure, I thought I'd offer a couple. So what are some of the assumptions of population health management that create some of these stories? So the first, I think, is the assumption that health of a community is primarily the product of individual behavior and respond to health education. Every instance of disease within the community can either be primarily addressed through regulating the behavior of individuals in those environments or reforming their environments and self to be more health promoting or disease preventative. Ideally, when health education is provided, it's by someone in that community who shares the same history and future of those that they are educating. We saw this, I think, in the examples of Kim McCann, as well as the CHWs working with Alex under El Sol. But public health management, I think, tends to push past this limit. It presumes that the answer to most health problems is making sure individuals have the right information about the issue to change their behavior. I think this tends towards imagining health as a private good, not something we co-create in common. I think it also tends to make health dependent upon some technical apparatus of information about the health issue in question, especially those that are kind of based in the scientific literature. We saw this in the trauma-informed care training I provided, as well as perhaps at the most extreme, the WHO's SARA chatbot. On the contrary, we can think about the examples of Stan and Mary Beth, who are trying to work towards reforming the environment itself to be more health promoting, and therefore encourages them and us to work outside of our disciplinary boundaries. Secondly, the health of the community can be addressed outside of wider concerns of human flourishing. So I think the scope of population health management, all its goals, strategies, metrics, outcomes, can tend to be constrained to merely physical health. Well, this could come across, I think, as a kind of respectfulness of staying in one's lane. I think without constraint, it can also serve various kind of technocratic assumptions. Expertise in any domain is weakened or challenged if the kind of information available to the experts is more accessible to a broader audience. And therefore, I think a lot of incentives exist to have both, expert knowledge as well as programming be as narrow or specialized as possible. In one sense, to presume that physical health is not the entirety of human well-being is to challenge some basic assumptions of population health management. I think we saw this most evidently in the case of the Canadian state's response to TB among the Inuit people, in which they were only interested in managing, a really statistical measure of mortality vis-a-vis tuberculosis. The problem of this vision, of course, is that the human person and human communities are complex wholes, and their needs extend well beyond, physical health to include all these other aspects of well-being. Attending to these diverse needs, I think, often requires a broader sense of human flourishing then, and therefore a kind of practical engagement with individuals and sectors that are not uniquely interested in physical health. And we think back to the work of the CHWs working with Alex Fajardo at El Sol. Perhaps their main interest was health, but this prompted them to work beyond that to address things like school absenteeism, things like mentorship among youth, things like developing safe places to exercise and recreate. I think this broader horizon is often evident in the work that I've done with Frank in the Faith and Mental Health program. When we speak with members of different congregations, it's much more likely for them to see issues of mental illness and substance misuse through at least, as much of a spiritual and kind of social lens than merely something biomedical or physical health. Additionally, there's an assumption, I think, often that the health of a community can be understood outside of the culture of that community. There's a lot of definitions of culture, what that means. I think generally it's just the particularity of, the mode of life, right, in which people occupy. And these are all the things that contribute to health and disease, our employment, where we are outside, the natural environment, what we eat, how we spend time with our loved ones. Not only does culture, I think, dictate all these kinds of determinants of health in some respect, but also there are ways in which we sacrifice our physical health for the sake of some cultural good. Disregarding this, I think, is a kind of malpractice that public health can participate in. Again, I think this was clearly the case in the Canadian state's response to TB. Because their singular goal was the prevention and treatment of tuberculosis, extension of life expectancy, they forcibly removed members of the community from their home, their ways of life, from their culture, often never to return, even if many of those individuals would have preferred some measure of risk, to preserve the culture in which they were inhabiting. Alternatively, the work of CHWs at El Sol is always done with respect towards the Hispanic culture and heritage of the neighborhoods in which they work within. Um, Fourth, the scientific method is assumed to be the best way to understand the health of a community and how to improve it. There are many instances in which modern science provides helpful and practical knowledge, obviously, of the workings of the body and how to facilitate its healing. And yet, I think within the kind of population health management model, there's a tendency to become over-dependent upon this method, which is, presumed to be homogeneous. This is evident, I think, in attempts to transform the complexity of a particular health issue into a number that can be more easily incorporated into some model, as we saw with the cost effectiveness amount analysis that I first presented. I think it's also present in the kind of proliferation of so-called evidence-based practices in public health, like what we saw with the calming rooms. The problem, I think, with evidence-based practices, with other examples, is that this presumption can easily dismiss, localized innovative strategies, as well as the importance of knowledge that can't easily be translated into scientific evidence. I think of all the encounters I've had with Kim McCann and other peer support specialists. Kim is not an evidence-based practice. She's a complex human person with a powerful set of lived experiences around this particular topic that's given her insight and solidarity. Um, um, and this kind of information, this background she has, is not easily measured or replicated. Um, Fifth, public health is like medicine at scale. I've heard many public health officials say something to the effect, that the community is my patient. And therefore, if an individual clinician administers one vaccine, we administer many vaccines. Or if there's one-on-one conversations with the patient, we have, health education campaigns with the entire community. Clearly there's a role for work that tries to scale medical interventions to be more accessible. And yet I think there can be a tendency, without the right limitations to, just replicate all the kind of harms of the purely biomedical interventionist approach in medicine into public health, where we see the community as someone that we have to diagnose, identify, treat with some kind of fix, to address the topic in question. An epidemic of depression must be fixed by expanding access to antidepressants, or an epidemic of diabetes must be, quote unquote, corrected, with targeted nutrition or exercise programs. And the last is that public health is best understood as an independent profession. So in its famous now reports on the future of public health back in 1988, the Institution of Medicine, or Institute of Medicine, now the National Academy of Sciences, of Medicine rather, defined public health as what we as a society do collectively to assure the conditions in which people can be healthy. That is the most important work, I think, of public health is not that which is done by an independent profession. We can talk about the ways in which it is helpful to have a professionalized workforce that is uniquely equipped, trained, paid, to address issues of health and disease at the community level. And yet, I think the examples I provided of folks like Stan, folks like Mary Beth, folks like Frank, suggest that all of us, from our unique sectors, our unique backgrounds, can be involved in the work of healing, especially at the level of whole communities. I think it's a danger often when public health thinks that it can work in isolation because it is an independent profession. So I think there's a sense in which all of these assumptions, become more real to the extent we actually implement them in practice. The more we develop metrics and systems of understanding health outside of wider concerns, the more we believe that health can be understood outside of wider concerns. And therefore, the more we address health outside of these wider concerns. The more we presume that the scientific method is the principal or best means to understand how to improve the health of the people, the less we attend to other forms of knowing. And therefore, the more dependent, we become upon the scientific method and these more technical forms of knowledge. I think this pattern is especially true, with this final implication, what I think is one implication among many, perhaps, of population health management, in which the community is seen, is treated, the posture towards it is as a stranger, not a friend. When public health does not have meaningful relationships with people in the community, they're implicitly regarded, I think, as strangers. And therefore, they tend to be managed, from a distance through all the anonymous techniques I've mentioned, scientific method, numbers, technical expertise, remote digital platforms, independent professionals, and so forth. I think to push back on any of the assumptions I've outlined is, in a sense, to invite relationality, to invite friendship, with people in the community. When one needs to attend to more than just merely physical health, one needs to attend to more parts of a person or more parts of a community, which tend to invite, additional dialogue. When we understand the role that a culture has in the health of a people, we become more interested in learning about that culture and developing programs and policies that are attuned to the particularities of that culture. When we presume that things like local knowledge, lived experience, and practical wisdom are essential parts of the work of public health, we need to build relationships with people who have those traits, again, as opposed to all the various anonymous techniques I've mentioned. I think this estrangement is perhaps most evident, with the WHO Sarah chatbot, as I show here. I think, look, with any engagement with a chatbot is a fundamentally kind of experience of estrangement or alienation. When you go to a chatbot with your questions about health and disease or questions about public health, you're stripped of the opportunity to form relationships, to form friendships with other people who may be experiencing something similar, or other folks who can direct you to people who are experiencing something similar. It's a feeling of isolation, of loneliness, as I think a lot of us can appreciate in other contexts as well. So I think there's a way in which reflecting on friendship and actually putting it into practice can be a kind of corrective. Not the only one, certainly, and friendship is not the answer to all of life's problems, but I think there's a way in which it can serve as a corrective to some of the worst of population health management. I won't go through all of these, but to just identify a couple of them. Friendship cannot scale, and therefore it resists the kinds of scalable techniques that I've mentioned in the first couple examples. It's oriented towards something. Friendship can never just exist for the sake of friendship. It's almost always about doing some activity, which I think we could think about as an example of culture. It cannot exist in the abstract. When you think about friendship, you think about, this particular friend, my friend, our friends, including all the folks that I've mentioned. I think about the work I do with Frank. I think about the work I do with Mary Beth, with Alex back in the pandemic. And it requires mutual agency. And perhaps this is, one of the more important ones. When you try to cultivate the conditions in which friendship is possible, you have to be attending to how, power differentials are working themselves out. Do people, on either sides of the partnership, of the friendship, have the same level of agency in directing, the course of that relationship or the course of that work? And mutual agency does not mean you're the same person. There's obviously interdependencies, there's differences, but you're working at a similar playing field as opposed to someone operating remotely, managing something, working in a more hierarchical fashion. Um, so the way I like to describe this other model that I've been trying to press for, health through friendship, is really simple. I don't want to overcomplicate things, make things too technically sophisticated, obviously. But I think there are just two questions that I think should guide public health if it's going to take something like friendship seriously in its work. The first is, how is public health cultivating friendship among the communities who are directly impacted by a given health-related issue? And the second is, how is public health cultivating friendship between members of the profession and members of the community? Um, I think the first question is more important than the second, as there are stronger networks of mutual care, of advocacy, of solidarity between people affected by an issue. There's a strong sense in which, the need for a kind of external professional individual is less needed. I think that's true in many parts of our life, especially in public health. Um, and yet, where there is a role for a member of the profession to be involved, I think we have to think critically about how can the work be structured in such a way in which there's all these attributes of friendship, at work between people who are formerly, belonging to public health and those in the community. Um, so I want to just rifle through really quickly, some normative reasons to push for one towards the other, and hopefully leave the rest of the time for a Q&A. Again, I'm going to rip through these pretty quick, so we have time for questions and answers. But, why friendship? Why now? I think many different reports have clearly demonstrated empirically the importance of friendship and social connection as a contributor to health and well-being. I just give a couple examples here in the slides. Again, we can revisit these as needed. Our friendships are declining, as the Surgeon General has indicated, among others. Rates of loneliness have been increasing, especially in the last few decades. Derek Thompson in The Atlantic writes of how self-imposed solitude may just be the most important social fact in the 21st century in America. So a search for friendship, is a search to try and counter some of these trends. Public health, the profession, is experiencing a crisis in trust, as has been documented in many different outlets, including the American Journal of Public Health. And it's hard for me to imagine an approach to trust building that is not at least trying to create these conditions in which there's, more meaningful engagement between members of the professional workforce and folks in the community. As C.S. Lewis writes in The Four Loves, to the ancients, friendship seemed the happiest and most full human of all loves. And yet, for us moderns, we tend to ignore it. Why do we do so, Lewis writes, is in part because friendship is the least instinctive, organic, or biological. And I think this challenge is especially relevant to public health. Folks who tend to think in terms of the organic, the biological, of things that are necessary to the species, so to speak. And so we should be especially kind of on guard to make sure that we're attentive to these to this idea and the importance of friendship within public health. Theologically, throughout Scripture, we're given many motivations of the importance of friendship, both for the sake of health and salvation. We have the famous story in Luke 5 of the man who is let down from the roof by his friends to encounter Christ. And we have this amazing passage where Luke writes, when Jesus saw their faith, he said to the man, "Friend, your sins are forgiven." It is a remarkable statement, I think, of the importance of friendship and community, both in one's journey towards healing the physical body as well as the soul. And then lastly, we have the model of Christ himself, who offers friendship to us. I think this is a underappreciated aspect of our relationship with Christ. I think people tend to be more comfortable speaking of Christ as a king, as a teacher, even the beloved. And yet, clearly, throughout the Gospels, especially towards the end of John, he invites friendship between us. So this is a Coptic icon from the 7th century that is a beautiful kind of representation of that. And so, if it is the case that Christ calls us to friendship with him and calls us to friendship with each other in the pursuit of both health and our salvation, I think we should very at least be critically thinking about how it pertains to the work of public health. Um, that is all I have. So thank you.
Thanks so much, Carl. Oh, so many fun things to talk about, friend. I really appreciate it. I see two questions here in the chat. We'll start with B Chen. Or question in the Q&A, I should say. Please do submit yours if you have some. B Chen asks, how do you define or describe to others the difference between a community and a population?
Yeah, it's a great question. To some degree, it's always hard to define something like community. You don't want to be overly prescriptive, overly kind of explicative. But I think one way that I've experienced it is a community is someone that is a group of people that have some kind of, shared history and shared future around some kind of activity. And I think when we think about communities within context of public health, I think about, what is the community around a particular health-related topic? It's not just those who are kind of directly affected per se, but also those who are trying to provide support for them too. I think when we talk about community, we also talk about membership in that community. We talk about particular names of communities. We think about the name of a church, the name of a town, the name of some social group, the Boy Scouts troop number, whatever. As opposed to a population that I think, tends to be more anonymous. It tends to be something that we mostly think of in terms and kind of bureaucratic legibility, the county, right, the state, as well as a particular instantiation of people.
Thanks, Carl. And thanks again for that great question, B. I'll invite Lauren if she's willing to come off mute and ask her excellent question that is very easy for you to answer, Carl, right here in the chat.
Oh boy.
Good morning, Carl. Thank you so much for your question. I am a pediatrician. And so the question, first of all, thank you. It was lovely. I agree with what you're saying. Sometimes scientists can be too sciencey and not enough of a human being. And I think you're absolutely right in what you're saying. But my question pertains to, at least in pediatrics, every day, we have a desire to be friends with our patients. We want that so much because we know it hinges on their overall wellness. But we feel that they don't want to be friends because our communities are so divided, and especially right now when it comes to vaccines, public health, people assume I am their state-sponsored enemy, and it can be really hard. So my question is it ever appropriate for the greater good to sacrifice a bit of our sacred cow of evidence-based medicine to preserve unity or to help in public health? It's I guess I'm asking, if I were to do that in my clinic, I might lose my job at the university. I don't know. So respond to that if you don't mind. How do we balance that as clinicians who are often just seen as part of the problem, especially in today's climate?
Yeah. I'm not a clinician, and so I cannot speak to all of the, challenges within that context. I'll speak about it within public health, but I think there are some generalities. I think what happens with the kind of language around evidence-based practices is it transforms, the work of a public health professional, if we could call it that, to someone who's kind of reaching for the shelf, to identify what is the right practice that kind of fits, this problem. And it's a good thing that folks have tried things before, and we can have a sense of where were things generally effective, how were they effective, in other contexts. But I really think, that discourse can be, weaponized a bit, especially when you're in a community discussion and folks bring up a particular issue, again, whether it's food insecurity, substance misuse, et cetera, and you say, okay, here are the 7 evidence-based practices that we can quickly, plug into this situation. And I think I've also found that, there can be a tendency, and I've felt this in my own career as well, to not really be critical about the practices themselves. They appear as though they just fell from the sky, are written in stone. The WHO has its list of evidence-based programs to address diabetes. And I'm curious often if folks who implement them have ever actually considered the history and legacy of the practices as such. And so I think at least becoming more, critical of the practices before we tried to implement them is one step towards building trust, as opposed to just quickly kind of reaching for the thing off the shelf. Yeah.
Thanks, Carl, and thanks again for the great question, Lauren. Um, Carl, I was reminded of your great institutions, which I truly do love Gillings, the nation's top public health school, as they'll remind you often. My wife has her PhD in maternal child health from there. It's a great place. But Carl and I have talked before about this wonderful tote bag that you can
Oh, Brett has to bring up the
um,
tote bag.
that has all these great innovations in public health. But it says, if you may not be able to read it, it says public health made your life better today. And Carl, I wonder if you could talk about the use of the possessive pronoun your instead of
Yeah.
our.
Yeah. Well, I agree. I think that one of the assumptions I mentioned is this, presumption that public health is this independent profession or best operates as this independent profession that's responsible for basically everything that's improved health in the 21st century or the 20th century. And I just think that's manifestly not true. If you think about all the different efforts that were made, especially at the early 20th century, to contribute towards expansions of life expectancy, not all of them were governmental public health agencies. There were, labor organizations that tried to develop, better regulations, at the workplace. Um, just one example. Obviously, all the stuff around sanitation and
Yeah,
uh, reform of streets and access to clean drinking water is not formally the public health profession. Um, so I think there can be this insecurity often, I think, in public health that wants to claim, a set of outcomes for itself, to legitimize itself. And I think in one sense, I understand that insecurity and that public health is very hard to describe, and I can talk more about that. But it's kind of grasping for, what are the things that we can kind of point to that identify who we are? And I think they will look towards these outcomes or look towards these particular policies. And yet, again, this what it does is it alienates people, and it makes it seem as though it's just us, who are responsible for improving the health of the public, which from many, many examples, I think is not true. And so, yeah, they should edit it. Maybe we could
yeah,
work on that.
yeah. No, it's great. One follow-up on that, and then my colleague Warren Kinghorn has a question that I'll invite him in a moment to come on with. But I was thinking about your account of friendship and your quote from Lewis, and is kind of echoing Aristotle, who famously describes these three modes of friendship of utility, pleasure, and kind of true friendship of deep virtue and
Right.
goodness. And it seems to me that a lot of the friendships that might connect up with public health are friendships of utility. Like we'll use one another
Hmm.
to get what we need. So I'm wondering if you have a story of kind of a friendship of utility shifting to something a bit deeper, a more truer friendship. And then I also wonder, Aristotle kind of famously describes it a thing that I think is largely sociologically true, which is that friends have to be similar in social status in all sorts of ways, that
Hmm.
you can't have too much difference for
Hmm.
friends. Now, obviously, the Christian witness here is radically different, that in Christ, as you were describing, who calls us friends,
Right.
friendship across difference can be bridged and united through the heart of God. So I wonder if you could talk about friendships utility to regular friendships, and then also this question of difference among friends.
Yeah. So in the chapter that Lewis offers in the Four Loves on friendship, which really is amazing, and I encourage all of y'all to read it. He also kind of talks about this differentiation where he says, there can be these kind of social matrices of cooperation or something, where there's clearly some kind of practical activity that people are engaged in. And this lends itself towards at least what he calls kind of companionship, in which you do have some interdependency. I need something from you, you need something from me. We're going to work together on this thing. And what I like about his language, and I think it is echoed in Aristotle as well, is these provide the kind of soil, in which deeper, more authentic, more virtuous friendships can emerge from. I think sometimes it's dangerous to think that there's a different path to that. I don't think you just fall into a friendship of virtue, like you do kind of need something to kind of maintain it and get people to know each other, get to know their strengths, their needs, etc. And so, just one example, I think a lot of, where public health can operate is maybe one step further or one half step further than mere friendships of utility, or at least providing the conditions in which that step is possible. And the work I've done with Mary Beth, I think, is an example where we met a couple years ago, in which she was trying to basically find someone from the university who could help her with, basically digesting some of the scientific literature or something around this topic. And um, we have had many, many interactions since then. And yes, I would say 80% of what we do is a kind of, we're trying to help each other out with different needs we have. But then it's blossomed into, we talk about many other things, going on in our life. And she's given many things to Marigold, my daughter, because she knows that I have a young child and she used to have a young daughter. We talk about challenges around parenting, and how to navigate that. I don't think she is my deepest, closest of friend, but I think there has been opportunities to take a little step further. I'd also say with Stan, it's been wonderful to get to know him more and his personal background. We almost always try to meet over lunch, or over coffee, and we have extended conversations. We're both educators, so we can have solidarity in the challenges of being in education regarding technology. And so, yeah, I think there's always opportunities to take that one step further. And I think what I'm just trying to push public health is to at least create those possibilities. It's ultimately up to individuals to take the next step towards something more virtuous.
Yeah.
Yeah, I think that,
And
yeah,
maybe what I would love to keep talking about that. And I want to get in a couple comments from the chat. I just want to recognize
sure.
Gary Gunderson's gratitude for your talk and how public health resonates with faith in many ways as opposed to interventional biomedicine and anthropology of exploring effective entanglements. And I was reminded in his comments of Paul Farmer drawing from liberation theology to talk of accompaniment. We've had
Right.
several of our theology, medicine, culture students and alums draw from that framework to reimagine the work of clinical medicine as one of accompanying, which bridges some to the public health realm, I believe. Lakeisha Bennett is gratitude for this and is going to draw some of it to Yale and um, sees it mattering, particularly at a time of war, which
Hmm.
I really appreciate her insight there. And Elliot Mame on the connections with the Ministry of Reconciliation and pastoral work. Martha Carlo, our colleague here, has a question that I'll invite her to come off mute and screen and share. Go ahead, Martha.
Great. Thanks, Brett. Carl, this was excellent. So many thoughts and openness for conversation. One hot spot that I feel like is in the middle of this is the professionalization of community health workers. So
Hmm.
community health workers have been part of churches and small
Right.
communities, and as a country, we raised up thousands and thousands of them during COVID, and now
Right.
they're being employed by health
Healthcare
systems,
systems. Yeah.
and like there's basically monetizing their work for health systems, pulling them over to the population health side in some ways. I wonder what your thoughts are about that and how they can balance really being true to communities while now working with systems and what you would support in that.
Yeah. I think there's a lot of ways in which the healthcare system has um, taken over various parts of public health or health prevention, disease prevention, et cetera, in the last couple of decades. I think this is one example of that. Um, I think core to the work of community health workers are all those kind of characteristics I mentioned, insofar as they can operate within that system in a way that respects the lived experience and personal background they have and doesn't try to commodify that too quickly so far as they have the agency in working with individuals in ways that they feel are best needed for those individuals and the way insofar as they have the supervision by folks who understand the complexity of that, I think is important. Again, I haven't worked with CHWs that are particularly in healthcare systems, so I'm not sure exactly all the complexities there, but I would start by asking them, where has working within a major healthcare system, hand strapped you a little bit, and doing the work that you once felt called to do, or the work you were once doing within a kind of purely CHW-led organization. I think it's an interesting topic for further reflection. But I'd start by asking them.
Okay, thank you.
Yeah, thanks, Martha. For our last question, I'll invite my colleague Warren Kinghorn to come off camera and ask.
Hey, Carl, thank you. First of all, that was just really brilliant. And I want you to know that we here at Duke are really grateful for your presence at UNC. It means a lot, actually, that you're a colleague with us there. So thank you. I guess I just wondered, I loved your kind of juxtaposition of thinking about management and thinking about an approach to public health based on friendship. And I just wondered how you would apply that as an educator to public health education and also to clinical and medical education.
Again, I don't have many answers for clinical and medical education, but I do think about public health, and it's hard to not think about, a educational program, training program, that reflects some of these ideals that's not, engaged in real people's lives, and learning from folks who have done this well, and giving them exposure, students exposure to, this is a community coalition that has, a witness to the best of these ideals, or this is a community leader that's done this work, for many years. And what are some ways in which we can apprentice, students in that space, as well as, giving them time to reflect and think more critically about what they're experiencing, what they're observing, trying to put it into a broader context. I've often thought that there's a sense in which public health education should be a little flipped, insofar as it should be like 80%, practical engagement in the world and like 20% kind of reflective, discursive dialogue. But to do that, you have to have partnerships and you have to have relationships, with people who are doing the work, and the faculty or the educators who are involved in it too. Again, part of it stems from this different kind of epistemology, of we tend to hire people in public health who have published fancy things about doing public health, as opposed to people who have done it. There are many reasons for that we could get into. But I think part of it starts by seeing the kind of expertise in a different location and exposing students, to that expertise more authentically.
Thank you. Thanks.
Yeah, thank you so much, Carl. I found myself wondering just now, how might epidemiology be a hindrance to friendship, and in what ways could it even potentially be an aid? So that just is fodder for further conversation, and I'm grateful to call you a friend and grateful for the
Likewise.
friends gathered on this Zoom near and far. And I invite you all to, if you haven't subscribed to our newsletter from the Theology, Medicine, Culture Initiative, I hope that you will. We'll be gathering in person at our Practice and Presence conference, or Gathering for Christians in Healthcare, this September 11th through 12th. You've got continuing education, CME credit info in the chat. And we hope to see you in our fall seminar series, which promises to be excellent, and also in person at Practice and Presence. But once again, Carl, thank you so much for an excellent talk and for the gift of your witness and the work you're doing there at UNC and beyond. Thanks, everyone.
Thank you.